Okay, good evening, everybody, and welcome to this My IVF Answers webinar by the European Fertility Society. My name is Eleanor Wharf. I'm a clinical embryologist working in the UK for more than 25 years now, and I'm also a professional coach, and my passion is to support patients through their fertility journeys. I'm really thrilled to have Dr. Abraham Zavala with us this evening from Clínica Tambre in Madrid, and we're going to see a presentation from him all about PGT, pre-implantation genetic testing, including PGT-A and all the other types of PGT that we have. So I hope that we're going to have lots of questions from you. We'll have a presentation first and then plenty of time to ask your questions. So please do put your questions in the Q&A and we will be able to answer all of those. So the session is being recorded, so you can always look back and see the recording when it gets to your inboxes tomorrow. So don't worry, you won't miss out on anything. And so I think we're going to go over to Dr. Zavala now for his presentations.
Yeah, thank you. Thank you for that warm welcome, Eleanor. Just one thing that I wanted to mention. I'm actually in Alicante. We have a clinic that recently opened earlier this year, and we are thrilled with the new facilities. Some of the pictures that we'll see in today's slides are from Alicante. So yeah, everyone's welcome to come see it for themselves.
You're on the coast now.
Yeah.
I love it. Okay, let's have a look.
Okay, great. Thank you. So as Eleanor said, my name is Abraham Zavala. I'm one of the gynecologists at Tambre Clinic in Spain. Just so everyone's aware, we have two clinics in Spain. We have one in Madrid that initially opened its doors in 1978, and a more recent clinic that we recently opened this year in Alicante, which is southeastern Spain. And today we're going to talk about the PGT-A process from start to finish. This, I think, is a very interesting topic. We'll try to find the balance between talking about the test itself and some of the specifics about it. But I also want to have some time to really get to the questions, because I think that there's an important logistics and practical factor that we need to keep in mind when undergoing PGT-A. So yeah, some of the topics that we're going to go over is we are going to give a brief overview of what pre-implantation genetic testing is. Most of the time we associate it with a specific type of PGT, which is PGT-A, but you'll see that that's not the only type of PGT that we have. We're going to talk about the types and the focus of each of the different pre-implantation genetic tests. We're also going to talk about how the test is actually performed, because I think that a lot of people forget that it involves a biopsy, and through a biopsy or a sample of the embryo, actually running the genetic sequencing to determine whatever we're looking for, really. In this specific presentation, I also want to give you a brief oversight of the Spanish regulation on PGT, talk about some of the recent research and evidence that we have on this test, and then I want to share with you some of the clinical cases that we've seen at Tambre in which we've used PGT. So the pre-implantation genetic test, PGT, is a test that we will use to determine the genetics of the embryo. Some types of PGT we can use to determine the amount of chromosomes that these embryos have. And that's sometimes what we refer to when we talk about healthy embryos. Sometimes we are looking for a specific gene, or sometimes we're trying to see how the chromosomes are arranged within the embryo. Now, PGT and a genetically fit embryo is something entirely different from embryo quality. In fact, PGT trumps embryo quality in the sense that a really good quality embryo, an AA embryo, for example, that is genetically abnormal will have will have less chance of having a successful pregnancy test than a lower quality embryo, but with a normal PGT result. Okay. And as always, there's really no test in fertility that can guarantee a successful pregnancy or a successful pregnancy test, but it's one of the tests that could potentially increase the odds of achieving pregnancy or reduce the chances of suffering a miscarriage. Now, this is something that I don't want you to take that in face value, because we are going to discuss some of the details in this information when we talk about the research and the evidence that we have on PGT. Just to put it in context, usually with PGT, it's one of the technological advances that we have in the lab of assisted reproduction or in an embryology lab. And this can sometimes go with other techniques such as not just PGT-A, but phenomatch, for example, when doing egg donation treatments, the Gary time lapse as one of the more important things that we do in embryos that we're planning on testing for PGT is seeing how those embryos develop. And through time lapse technology, we're able to see not just the quality of the embryo, but how the embryo got there, which can sometimes be a determining factor in deciding which embryo to use. We have other tests such as comet fertility that assesses the sperm fragmentation, which is a valuable piece of information that we can have when trying to generate healthy embryos. The RI Witness, which is a technology that makes it safer for us to work with each patient's gametes or cells. It's a way to ensure not just by standard IVF protocols or lab protocols, but also an electronic system that ensures that we're using the right cells and right embryos for the right patient. All right, so the pre-implantation genetic test is something that has, over the recent years, definitely gained momentum. In this simple bar graph, we can see the blue lines talking about the percentage of clinics that were using PGT technology in 2016 and the percentage of clinics that have been using PGT in the subsequent year, in 2017. As you can see, 10% of the clinics used PGT in 75 to 99% of the cycles. And in 2017, we had 3% of the clinics that were using PGT in 100% of their IVF and egg donation cycles. Okay, now there isn't a right or wrong answer, but this is definitely a thought exercise that we can keep in mind when talking about the information on PGT, because even though it's a technology that can provide us with a lot of information, it's important that we keep in mind that in fertility, there's no one size fits all. And there's also very few tests that we can use routinely in any given context. Okay, so there are three types of PGT. Okay, there is the PGT-A, which is by far the more commonly used PGT or type of pre-implantation genetic test. When people refer to PGT, they usually mean PGT-A. And what this test is going to analyze is the amount of chromosomes that an embryo may have. We know that an egg cell has 23 chromosomes and a sperm cell has another set of 23 chromosomes. When they combine, they should have 46 chromosomes. Now, this isn't always the case. Sometimes it may be due to a person having an abnormal karyotype, so an abnormal arrangement of their chromosomes. But sometimes both parents can have the healthy amount of chromosomes, an egg cell with 23 chromosomes and a sperm cell with 23 chromosomes, that when they match, for whatever reason, the embryo doesn't have 46 chromosomes. And this happens because there can be errors that occur when the embryo is developing. And sometimes this can be due to a poor egg quality, or it can be due to a sperm quality. But the more frequent cause is usually attributed to a diminished egg quality. Now, the second type of PGT is the pgt-m, which stands for, the M stands for monogenic. That means single gene. So this is the test that you would use if you were looking for a specific gene. So the PGT-A, for instance, that's going to tell us the amount of chromosomes, but it's not going to give us any information of how those chromosomes are arranged or the contents of those chromosomes. We have to remember that genes are sequences that make up the chromosomes fabric, but you can count the chromosomes and not necessarily know what's inside of them. And that's where the PGT-M comes in. It can look for a very specific gene that may be abnormal in one of the parents. And finally, there's the pgt-sr, okay? Now, the pgt-sr, or the PGT for microarrays or structural rearrangements, is going to do just that. So, for example, if we had one of the parents that had what we call a balanced translocation, that means that maybe one of the chromosomes is stuck to another, they're going to have the same amount of genetic material. But when those chromosomes are segregated, they may be segregated in a way in which they end up as an unbalanced translocation, right? So the pgt-sr would be the test that we would use to make sure that not only that all of the genetic material is there, but it would also tell us how that material is arranged. So there are many reasons why we may decide to use the pre-implantation genetic test. It can be anywhere from being a known carrier of a specific disease, maybe trying to rule out a familial cancer with an underlying genetic cause. Maybe one of the parents, as I said, has an abnormal karyotype, such as a balanced translocation, I'm sorry. Or women or men that may have a normal karyotype, but may have an increased chance of having an abnormal embryo, or an embryo with an abnormal number of chromosomes. For instance, women that are over the age of 37 or 38, in which is a population in which you would want to make sure that the embryos that you're getting have the normal amount of chromosomes, but also in women that are struggling with RPL, or recurrent pregnancy loss, or recurrent implantation failure. This, the former meaning women that have had more than two miscarriages, or the latter, referring to more than 2 embryo transfers that haven't successfully attached. Mind, we're talking about transfers that have been with with good quality blastocysts. So I think that it's important that we talk about the more common type of pre-implantation genetic test, which is the PGT-A. Okay, the reason why it's the most common, as I've said before, it's because it's going to test for aneuploidies. Okay, aneuploidies means having an abnormal amount of chromosomes. If you have 46 chromosomes, we would say that that embryo is euploid. If that embryo has 39, 46, 47, or 92, or any other combination that is not 46, then we would say that that embryo is aneuploid. Now, we know that aneuploidy increases with age. Well, it actually, if you look at the graph, it actually decreases with age as well, because we can see that there is a lower chance of having an aneuploid embryo at 28 than there is at 22. Okay, that's why this graph has that kind of J-shaped curve to it. But we know that roughly after the age of 35 to 36, the chances of having an aneuploid embryo do increase significantly. This has been linked to poor egg quality. It's not that the eggs or that the oocytes suddenly can't generate a healthy embryo, but we know that with the ovarian reserve, women are born with all of the eggs that they will use throughout their lifetime, and those eggs that aren't ovulated during the first 35 years of a woman's life can accumulate a significant amount of oxidative stress, bad lifestyle choices. Also, it can decrease its genetic ability to achieve a healthy embryo. So as you can see, the euploid rate decreases as age increases. Okay, so under the age of 35, we have a euploid rate of about 60 to 70%, compared to women over the age of 40, in which we can expect that out of every 10 embryos, roughly 2 might be chromosomically normal. Okay, and this is a summary of the different types of pre-implantation genetic test and what their purpose would be. So, for example, a PGT-A is a way in which we can study the chromosome aneuploidy in embryos, and the key purpose is twofold: increasing implantation or increasing pregnancy rates and reducing miscarriage rates. We have to remember that the leading cause for miscarriages at any age really is an aneuploid embryo, an embryo with an abnormal number of chromosomes. This is usually targeted in women over the age of 37 or women that are struggling with recurrent pregnancy loss. PGT-M, on the other hand, looks for single gene mutations to prevent diseases that may have a certain pattern of inheritance. Autosomal, dominant, recessive, it doesn't really matter. As long as the condition has a single gene underlying cause, this is something that PGT-M could look for. And then finally, the pgt-sr that we mentioned looks for structural issues, parents with certain chromosome rearrangements, such as translocations. Also, deletions or microdeletions, this is also something that PGT-sr might be capable of searching for. Okay, so now this section I think is very important because, it in theory, it makes a lot of sense to do the pre-implantation genetic test, whether it's the PGT-A, pgt-sr, or pgt-m. However, it's important that we understand that this is an invasive process. Okay, we'll talk about the regulation for it, the ethics behind it, but we also have to understand that it is an invasive process. So PGT can be performed in day 3 of the embryo's development. The reason why we don't do that, we'll explain a little bit later on, but today we wait until the embryo arrives at a blastocyst stage, which is usually on day 5 or 6, at which point the embryologist will take a sample of the outer ring of the cells called the trophoblast, and those are the cells that will be analyzed. Okay, this process can take anywhere from a day to 3 weeks. Okay, and during that time, since you're waiting for that result, the embryos must be frozen. Okay, that's why doing a PGT, regardless of whether it's A, M, or SR, will always be a frozen embryo transfer. Okay, so these are some of the more important stages of the embryo's development. Okay, first we have the egg cell, then we have a day 3 embryo or a cleavage stage embryo, and finally we have the blastocyst or a day 5 or 6 embryo. And these are this is a bit of a kind of history lesson, because this is the way that the genetic analysis of the embryo started. So what you see in the first image is the egg cell's division. Okay, so when the egg cell divides, one of the cells keeps developing. Okay, and that's the cell that will be fertilized by the sperm cell, and the other cell becomes a polar body that will no longer divide, but we can see it. And theoretically, it should be genetically identical to the other cell. So we used to take that polar body and analyze it genetically. This, of course, doesn't include how the embryo what type of genetic result the embryo will finally yield. So we no longer do this type of genetic testing. Then, as I said, we started doing the PGT on cleavage stage embryos. Now, as you see, there are plenty of cells, not that many, but there are plenty of cells. But they're all one group of cells. Okay, so the embryo, if you take 1 or 2 cells from an embryo that has a total of 8 to 10 cells, you might be taking a lot of its genetic material. So that's one of the reasons that we no longer do day 3 biopsies. The other reason is because you don't know where that cell's coming from and what that cell was going to become. But one of the key aspects of a blastocyst is that for the first time in the embryo's life, there are 2 distinct cell lines. There's one cell line that's going to become the inner cell mass, which will go on to become the fetus, and baby eventually, and the outer ring of cells called the trophoblast, which is the cells that will become the placenta. Okay, so when we do a pre-implantation genetic test, those are the cells that we take the genetic material from. That's the group of cells that we biopsy. Not the inner cell mass that will become a fetus, but the cells that will become a placenta. So how is the pre-implantation genetic test performed? So at a biological level, or at the level of a lab, what most labs tend to use nowadays is the NGS method, which is the next generation sequence. And this is the faster and more efficient way of analyzing the genetic components of the embryo. Now, when we do NGS, okay, the result from the PGT-A, specifically speaking about the PGT-A, can be one of three main diagnoses. Okay, so the embryo, as I said before, can be euploid, meaning that it has 46 chromosomes. It can be aneuploid, whether it's missing a single chromosome, whether it has just an extra chromosome, or whether it has 3 whole sets of extra chromosomes. It's going to be categorized as aneuploid. Okay, but there is also a middle term called mosaic. Okay, now a mosaic embryo is when you have 2 different cell lines within the embryo. Okay, this sounds quite impressive, but really, even euploid embryos can have some amount of different cell lines. The threshold is just very low. It's depending on each lab, but it's roughly about 15%. Okay, that means that even euploid embryos can have a distinct cell line in up to 50% of their genetic material. Mosaic embryos, on the other hand, usually have anywhere from 15 to up to just about 50%. And depending on that different cell line, we may get a high-risk mosaic embryo or a low-risk mosaic embryo. Mosaic embryos can become perfectly healthy pregnancies, but when compared to euploid embryos, they do have a lower implantation rate. And we usually recommend a closer genetic analysis during pregnancy, not just using a non-invasive pregnancy test, but also using sometimes actual invasive tests such as amniocentesis to try and be as sure as possible that the pregnancy is genetically healthy. So regarding the Spanish regulation, this is all picked up by the Law 14/2006, and the Spanish law allows PGT in assisted reproduction. Okay, now depending on the type of PGT, the law will regulate it in one way or another. So usually you'll be able to do a pre-implantation genetic test. This is something that is regulated by the Ministry of Health in Spain, and the guidelines are provided by the Spanish Fertility Society. And this is something that the state has to be aware about, of the PGTs the PGT-As that we're doing. But it's usually not going to intervene with when deciding on whether or not to do a PGT-A. This is a choice that can be up to the patients, but it's important that they're adequately counseled to know whether PGT-A is something recommended in their case or not. And as I said, along general lines, we're going to recommend PGT-A in women over the age of 37. Or in women with recurrent pregnancy loss or recurrent miscarriages, or with parents with abnormal karyotypes. Now, pgt-m, on the other hand, is something that is more regulated because Spanish law focuses on preventing serious lethal diseases of early onset. Okay, we're looking for specific gene sequences that we know are associated to serious diseases, and there are some diseases that the law pre-approves, such as cystic fibrosis or Huntington's disease, that we can do a pgt-m for. Okay, other diseases we need to ask the what we call the CNRHA, which is the Committee for Human Assisted Reproduction. And they're the ones that determine whether we are able to do PGT-M or not. Okay. So, for example, when we do genetic matching tests, sometimes we'll get sequences of unknown significance. That means that it's not a normal sequence, but we're not entirely sure whether that's a bad thing. Those types of mutations or gene sequences are probably not going to be approved by the committee when deciding on PGT-M. Okay, so this process, if the condition that we're looking for isn't in the pre-approved list, then we have to go into a process to see if the committee would allow us to do the PGT-M. Normally, this takes anywhere from 6 to 12 months, and it usually involves not just genetic reports, but it may also involve sampling not just the parents for the embryos, but sometimes even the parents, so the grandparents, especially when trying to see where that mutation can come from. Okay, now this is something that that we have to keep in mind when doing genetic matching tests. Again, genetic matching tests are tests that don't have anything to do with fertility treatment success rates, but they are an important tool that can help us get information on the offspring that we may have. Okay. Now, when doing the genetic matching test, what we're essentially doing is looking for carrier mutations. That means mutations that we may have, but we may only be carriers for. That means that we would, for example, so cystic fibrosis is a great example for this, because this is a recessive mutation, meaning that you need 2 abnormal copies in order to have the disease. Now, if you just have 1 abnormal copy, then you would be a carrier of that mutation, but otherwise healthy, meaning you'll have the mutation, but you won't have the disease. Now, if your partner also has that mutation, there's a 1 in 4 chance that your child might actually have cystic fibrosis. Now, mutations like cystic fibrosis or muscular dystrophy, those can be studied with PGT-M. But there can be certain mutations that come up that may not allow you to do a PGT-M. And this is the part where you have to be adequately counseled by a geneticist in order to understand that risk. Now, there are important benefits that you can get from PGT and important limitations that you have to be aware of when deciding whether this is the right test for you. Okay, so PGT-M and pgt-sr, those are types of tests that, other than being a strong filter for the embryos that you have, I think it's the value that they bring to the table is quite obvious and quite clear. But with PGT-A, there have been mixed results when analyzing the evidence. Okay, but I think that a way that in which I could summarize it is, PGT-A is not perfect. Okay, it's an invasive test that, if you compare the PGT-A healthy embryo to an untested embryo, the chances that you'll achieve pregnancy are higher with a PGT-A tested embryo, okay? If you only compare that single transfer, because PGT-A is not a treatment in the sense that if the embryo is abnormal, it'll just tell you that it's abnormal. And if it's normal, you'll have that result as well. But with untested embryos, you just don't know which embryo is healthy or not. So if there is a healthy embryo within that embryo batch, then you will achieve pregnancy as well, right? Or the odds are that you'll achieve pregnancy at exactly the same rate as if you as the genetically tested embryo. So it doesn't increase the chance of achieving pregnancy on its own. It just does that within one embryo transfer, okay? The other advantage of doing PGT is that it could reduce the chances of having a miscarriage. And I think that this is almost just as medically relevant as increasing the pregnancy rates, because we know that a miscarriage not only carries a strong emotional toll on not just the woman, but also the couple as a whole. But it also opens the door to potential complications. So we really do want to reduce miscarriages. Does it eliminate them? No, absolutely not. But it can reduce the miscarriage rate. And there's also a sort of elephant in the room when discussing PGT, because we have to remember that PGT is a medical test. And with any medical tests, you're going to have false positives and false negatives, okay? So what if you have an embryo that was considered aneuploid, but was really genetically competent? Can this happen? Yeah. There's a very low chance that this can happen, but it is possible. So like any test, we always have to weigh the risk and rewards when deciding whether this test may be right for the couple undergoing, or the woman undergoing IVF. Recent studies have shown that that there really isn't much difference when comparing PGT in women under the age of 35, but that difference does seem to increase significantly when comparing it to women under the age of 35. Now, this graph may look impressive. I mean, you're seeing the 40 to 42 age group, and you're seeing a pregnancy rate or a live birth rate, I guess, of 40% in women with PGT-A compared to 10% within the same age group. But we have to remember that there's a very important bias here. And that is that you can only do PGT in women that have had eggs upon collection, and that those eggs have made it to blastocysts. And studies in which you compare pregnancy rates with or without PGT-A based on the amount of eggs collected, those results aren't as clear as the graph that we have in front of us right now. So recent studies and recent meta-analysis have shown that, for example, there was a recent analysis by the American Society for Reproductive Medicine in 2024. It's not proven for routine use in IVF, but considered in women of advanced age. By advanced age, they mean women over the age of 37, okay? X-ray guidelines consider it an add-on. And they highlight the fact that there's limited evidence for the success of PGT, and safety concerns are still patent for long-term child outcomes. Now, quickly, I want to talk to you about some of the actual conditions of which we've used PGT. So, for example, in case A, we have a female of 31 years old with a really good ovarian reserve, or 8 nanograms. I think that this isn't just a good ovarian reserve, but a really good ovarian reserve, even compared to other 31-year-old women. Her partner is a 30-year-old male that has been diagnosed with osteogenesis imperfecta type 1, which is quite a severe disease with an autosomal dominant pattern of inheritance. That means that if you have even one gene, you'll most likely have the disease. The sperm sample was also low on morphology, and it had an elevated rate of double-strand DNA fragmentation. Now, we did an IVF cycle in which we got 24 eggs. And remember the fact that we got 24 eggs from a healthy 31-year-old woman. So we got 24 eggs. 18 of were mature, which is a normal maturity rate. We got 10 embryos, 6 blastocysts. We then ran the pgt-m and pgt-A analysis, and we had a total of 2 embryos that were euploid and that did not have the gene that we were looking for. Okay, this is important because there could have also been aneuploid embryos that had the gene, or euploid embryos that had the gene. Okay, but in this case, they had 2 euploid embryos that were unaffected or didn't have the gene. We did 1 frozen embryo transfer, but the pregnancy rate was negative. The pregnancy test was negative. And then we did a second embryo transfer, which yielded a positive pregnancy test. She had an unremarkable pregnancy, meaning that nothing abnormal happened, and they now have a healthy newborn. Okay, so in that case, we used pgt-m, looking for that specific gene. Case B, we have a 39-year-old woman with a normal ovarian reserve of 1.6, normal female karyotype. Her partner, 32-year-old male with severe oligoasthenospermia. That means that low concentration and very low motility, with an abnormal karyotype, because the chromosome 10 and chromosome 14 were translocated. That means that they could have been stuck to each other. Okay. Now, there's 2 types of pgt-sr. I don't think that we have enough time to talk about this, but you can either choose to know which embryos have the translocation but are balanced, and which embryos just have a normal karyotype. Okay. In this case, we did, because we were expecting to need as many eggs as possible due to the ovarian reserve, we did a dual stint. That means doing 2 back-to-back cycles. First round, we got 5 eggs, from which we got 2 blastocysts. Second round of IVF, we got 16 eggs, 5 blastocysts. We ended up having 1 euploid embryo that actually came from the first cycle, had a normal pregnancy, positive pregnancy test, normal pregnancy, and a healthy newborn. And the last case that I want to talk about is a 44-year-old female that had a really good ovarian reserve for her age, a 40-year-old partner with an abnormal sperm quality. She had 18 eggs, 10 mature eggs, 7 embryos, 2 blastocysts. Those 2 blastocysts, luckily, were both euploid. She had 1 positive pregnancy test that unfortunately ended as a miscarriage. And then for a second frozen embryo transfer, we had a positive pregnancy test and a normal pregnancy. Okay, so that about wraps it up. And now I'd be happy to answer some of your questions.
Thank you so much, Dr. Abraham, for that comprehensive presentation. We've really heard a lot of detail there, and I just want to dive straight into some questions now because we are a little bit short of time. So the first question is, what is a low-level mosaic? And the second part to that question, can mosaic embryos be retested and result as euploid embryo? So if you retest, can you get a different result? So we have a few questions about low-level mosaics. So please, could you let us know?
Yeah, so this is something that I briefly talked about during the presentation. As I said, a mosaic embryo is going to be classified as low or simple. So low is going to be when there's a low percentage of an additional cell line. Okay, this is going to depend on the lab's references, but it's usually below 30 or 40%. And when we talk about a simple mosaic, it's going to be based on the number of chromosomes that are affected. Now, when if you retest an embryo, can the result be different? Well, theoretically, it can, because when you analyze a sample of the embryo, you're not analyzing the whole embryo. You're analyzing a group of cells, and based on that sample, you're going to determine the genetic content of the embryo. So having said that, it's not something that we would usually recommend, but it's definitely an embryo that, in absence of euploid embryos, we would consider transferring.
So I think the question about retesting embryos is perhaps, I mean, for me, this is my bread and butter, is embryo biopsy. So I think there are some embryos that would be suitable for us to retest, depending on the quality and the number of cells in the blastocyst.
Yeah,
so
because this is something that can happen with not just with mosaic embryos, but with any embryo. Sometimes we'll get a very frustrating and disappointing result, which is not enough material or not enough material to determine the genetic content of the embryo. Now, we always have to weigh the context of the situation to determine whether that may be the right choice for us. Normally, one of the things that we recommend, personally, sometimes I think that it's better to just transfer the embryo because retesting involves, so that embryo has already been frozen after the biopsy, and retesting it would imply thawing the embryo, freezing it again, and then if it's euploid, thawing it once more to transfer it. Okay, so as Eleanor said, based on the number of embryos that you have, the quality of the embryo that you're thinking of retesting, you can discuss with your doctor whether that may be the right choice for you.
I mean, I think the question about if you retest it, you might get a better result, but also to remember you might get a worse result as well. So it's not all, the results are not always reproducible because we have this issue with mosaicism of embryos. And I think there is some evidence to show that embryos that have been re-biopsied, so some more cells taken away from the embryo, tend not to do as well. Once you've taken a second biopsy, the chance of that embryo being able to compensate for the loss of cells perhaps is a little bit lower. So pregnancy rates tend to be a bit
lower. That's a conclusion, right? Because you don't really know what the factor is. I mean, is it the refreezing, rethawing, or is it the amount of cells that you took, right? So I think that that's one of the conclusions that you can draw, but not necessarily the exact reasoning as to why they may have a lower implantation potential. But yeah, definitely something interesting to consider.
Another quick one. How accurate is PGT-A today? What happens when you get a false positive or mosaic? How often does this happen? Presumably that's to do with the company that you're using. So different clinics use different companies to do the genetics testing. So it's not something you do in-house.
Yeah, and as an added layer, you also have to remember that when you read studies about this, the methods that they use are sometimes more precise than commercial PGT testing. So academically, the evidence has shown that embryos that are deemed aneuploid but that are actually euploid can happen in about 2% of cycles, okay, or 2% of embryos. But with commercial companies that do these tests, that percentage can be slightly higher.
Okay, thank you. So just going on to a bit of a longer question here, a bit more of a personal detail. So thank you for your question. This patient is 39 with endometriosis, poor egg quality, had an egg retrieval in 2024, one euploid embryo and another low-level mosaic deletion embryo. Very sadly, they're saying that the euploid embryo was transferred but had second trimester loss. I'm so sorry to hear about that, and I really hope that you're getting some good support from your clinic after that happened. And now you're left with the mosaic embryo. So your question is, you want to understand what's the chance of that embryo working, the specific definition of that type of mosaic, a deletion, and what's the problem associated with that deletion.
Yeah. Okay. So first of all, very sorry to hear about your loss. And regarding the mosaic embryo that you have left, we never want to hear that there might be a genetic issue with our embryos, because we think of the impact that it can have on our children. The experience that we've had with mosaic embryos is that they have a lower chance of implantation, a lower chance of developing as a healthy pregnancy, slightly higher chance for miscarriage. Okay, we recommend that patients that have a mosaic embryo transferred also have amniocentesis to make sure that the embryo is, or at that point, that the fetus is chromosomically normal. It's not often that a simple or low mosaic embryo becomes chromosomically abnormal. It is a theoretical risk, though. But also thinking about the regulation, at least in Spain with mosaic embryos, because usually if you have embryos that are frozen, you should use those embryos before generating new embryos. But with mosaic embryos, you can choose to do another IVF cycle, because mosaic embryos are regarded as something that you would use if you don't have any euploid embryos to transfer. So I think that it's important that you discuss with your clinic whether maybe undergoing another stimulation cycle, or whether trying to transfer that mosaic embryo might be the right choice for you.
I wonder if I can also ask you, Dr. Zavala, about whether you have genetic counsellors in your clinic. Just a conversation about the genetics, what that specific deletion actually means, what's the chance of having, a live birth of a child that is affected by a genetic condition.
Yeah, absolutely. That's a very important aspect. I love boasting that our clinic, we do provide genetic counseling when discussing abnormal karyotypes, mosaic embryos, genetic matching test results. But it's also important that patients know that most genetic labs, or most genetic testing companies also provide genetic counseling if you ask for that.
Great. So just one other question here, asking what is the cost difference between PGT-A and pgt-sr? So this patient has a balanced translocation on the Y chromosome. So they only need to test male embryos, but they've heard it's dangerous to thaw a frozen embryo and then test at a later time for pgt-sr. So I think they're wondering whether they would need to have two different tests, so the PGT-A and then the pgt-sr. What do you think?
So about this, I would ask the clinic that you're doing this treatment with how the lab tests for embryos, because something that I actually didn't mention in the presentation is that when labs run either a pgt-m or a pgt-sr analysis on the embryos, they're also usually going to do a PGT-A as well, because they don't want to risk transferring an embryo that doesn't have the translocation or doesn't have the gene, but it has an extra 21 chromosome, or it's missing a very important chromosome. So most labs will do both tests at the same time when doing PGT-M and pgt-sr.
Yes, I agree.
And just one last thing I want to add about that is that PGT-M and pgt-sr usually involve doing additional genetic testing on other relatives in the family. So that usually increases the cost of the test, which is something that you normally don't do for PGT-A. For PGT-A, you don't even really need the karyotypes. I think it's a great idea to have them, but it's not something that the lab's going to require. But for PGT-M and pgt-sr, sometimes they're going to want to know where it comes from to see how to look for it, and they'll recommend doing what they call pre-PGT, which is doing the genetic tests of the parents or the relatives before actually testing the embryos.
Mm. So in this case, hopefully there would only need to be one embryo biopsy and one lot of testing, which would then only test the male embryos for the for that translocation.
Sorry. If that was the question, then it's they're able to gather that information from a single biopsy.
Okay, so a few more questions coming in quickly. So I think we've got a follow-up question. How do I know more about deletion 7? So just referring to this.
With any deletion, it really matters where the deletion is at, what part of the chromosome and what genes it could potentially affect. So I think that that's something that you should have genetic counseling for, so that you can have more information on that. Okay, but also remember that this would be something that would only be in the secondary cell line. And the importance that that has is how is the percentage of that secondary cell line. So this is something that you definitely need to ask your geneticist in genetic counseling.
Yeah. Also important to know, I think we don't really know everything about embryos yet. We're still discovering new things. So I think in the last few weeks, it's been quite a controversial time.
That's an excellent point, because one thing that I didn't touch on is that we don't know the ability that the embryo may have to repair itself. Okay, we lack that information of how much of an ability it has and at what point it does that. So there is still a huge unknown area when it comes to embryos.
Yeah. Some suggestions from research coming out last week, I think from Cambridge in the UK, suggesting that actually embryos might put those abnormal cells into the trophectoderm to avoid those cells being in the inner cell mass, which goes on to the fetus. So perhaps embryos are much cleverer than we really give them.
And unfortunately, that's where we would catch them. And that's part of the reason why, for example, with a mosaic embryo, we wouldn't recommend just doing a non-invasive pregnancy test, because the non-invasive pregnancy test analyzes the cells from the trophoectoderm that are within the mother's bloodstream. So it's it would give you the same information as a PGT, but it wouldn't give you information on the inner cell mass cells, which at that point would be a fetus, right?
Thank you, Dr. Zavala. So another question here, how can we check that the lab that does the PGT-A, so presumably the genetics lab, has good equipment and experience, and what are the questions you could ask?
Okay, before I answer that, I do want to answer that last question because I think that that's a very important question, which is, do you recommend PGT-A in egg donor embryos?
Donor embryos, okay.
We run out of time.
Yeah.
Normally, no, we don't recommend PGT-A on donor eggs because it doesn't seem to improve the chances of achieving pregnancy. However, in cases in which we have recurrent miscarriages or recurrent implantation failure, we may want to be sure that the embryo that we're transferring is chromosomically normal so that we can, uncover as many variables as possible. So we know that it's not the embryo and that it may be something within the environment of the in which we're transferring that embryo. Okay. Now, regarding the equipment and experience of the companies that analyze PGT, that is, in theory, a question that you would want to ask. But in practice, unfortunately, I think it's really hard for you to know that up front because most of the time you don't know what company the clinic that you're at works with. Some clinics may have their own genetics unit that may not do PGT-A just because they're called a genetics unit. But some actually do have genetic units that do analyze their own embryos. But most clinics will outsource those genetic analysis to other companies. I can't mention them in this webinar probably, but there's quite a few of them. So if you're really interested, that's a question that you could ask your clinic and get more information on the different companies that run these tests.
I wonder if one question people might ask is, what is the misdiagnosis risk? Which is something that these genetic companies should provide information on so that you get an idea about, the quality of their testing, how often they get it wrong, because, that's an important thing to know. It would be a reflection of the quality assurances that company might be able to give. They should be able to give some information about that.
Yeah, that's information that would be nice to have. Yeah.
Yeah, and that your clinic should be able to tell you which company they use for the genetic testing. That should be quite transparent, shouldn't it?
Absolutely.
Okay, I think we've come to the end of our questions this evening. We've come to the end of our time as well. So unless anybody has got anything really pressing at the last minute, I think we're ready to finish the session today. Thank you so much, Dr. Zavala. It's really been a lot of information, and don't forget, you can always have a look at the recording. Should be sent in your inboxes tomorrow, just in case you missed any of the information or just want to have a look at it again. So thank you so much, and thank you everybody for attending, and thanks for your brilliant questions. And wish you all the best of luck in your forthcoming treatments.
Okay. Thank you, Eleanor, and thank you everyone for listening to this session, and have a good evening.
Good evening, everyone. Oh, hold on. Sorry, I was about to finish, and there's just one more question. Okay, so Christina, we're going to just this will be our last question now. The procedure of PGT of cells embryologist takes, is it easy? Can it be done by any embryologist, or do you need experience and special equipment? I wonder if I might be able to answer that, Dr. Zavala.
Not every embryologist is going to be capable of doing PGT. Okay, yeah. That's a reality. most embryologists that are able to do PGT, so they're not actually going to analyze the genetic material, but they're going to take the biopsy. They usually, what they'll do is they will make a small incision with a laser in order to have some of the cells from the trophoectoderm kind of poke out. And that's the zone that will, or the cells that they'll extract to send off for genetic testing. It is a very delicate procedure. And it's not just the technicality for doing the procedure, but also it has to be at the right time in the embryo's development. So it's something that more senior embryologists might be able to do. I'm sure there are some clinics that don't have any embryologists capable of doing the embryo biopsy. What they'll do sometimes is that some of these companies that analyze the PGT will have their experienced embryologists go to those clinics and do the biopsies. So that way, making sure that whenever a biopsy is performed, it's always done by an experienced embryologist.
I would agree. I mean, I think in the team where I work, there's only a proportion of the embryologists that are trained to do embryo biopsy. It's like any other technique, like for instance, the ICSI technique. You need to have special training. You need to be able to practice and make sure that you're confident before you actually do clinical cases. So it's the same thing for embryo biopsy. There are slightly different ways of doing embryo biopsy. They're all very intricate and difficult to do, but it is like anything else. The more that you practice doing them, the more the easier it becomes. And actually, after many years of experience, it does seem, actually just another thing that you do in your job. So for embryologists, that's our job. And we're very competent and very good at doing it. And we always have quality controls in place to make sure that we're keeping up our skills and we're not damaging embryos as much as possible when we're doing the biopsy. And on that note, I think we have finished all of our questions. So once again, have a great evening, everybody. Thank you very much, Dr. Zavala, and hope to see you again sometime.
Yeah.
We have a few more My IVF Answers webinars going on this week. I think there was one tomorrow and another one on Thursday. So lots for you to watch and lots of information out there for you.
Okay. Well, thank you and have a good night.